Welcome to the next episode of Mic'd Up with ChiroUp. Today's episode is going to cover the age-old debate on using heat versus ice therapy. You're going to have Tim and myself for this episode, and I'm going to have to explain why I had to call him in for this episode. And really the reason is because this topic is well above my pay grade.
And ratings were dropping.
That's probably what it was. Just as a reminder, if you haven't yet, hit the follow button and share this episode with a friend. It does help us reach more evidence-based DCs like yourself, really around the world. And I think this is one of those topics that you're going to want to hear. And we're going to keep this short and sweet. However, this is a topic that I really do believe I hear about, at least on a daily basis. And the solution sounds simple. However, we're going to examine the facts and not just the opinions on how to explain ice therapy and when to use it as compared to heat therapy. Now, we're going to set the record straight on this old wives' tale. So sit back, put your tray tables up, seats in an upright position. There is going to be some turbulence during this episode, sometimes in your head, sometimes through our discussion, but really we're going to prepare ourselves to kind of change what science has told us in the past and also learn from it and how we're going to move forward, as far as our education and also how we educate our patients, of course, with the common goal of the patient's needs first. So topic of debate for today, heat versus cold therapy, which is best for musculoskeletal injuries. And as you know, we try to stay in that realm. We're not going to dive out into the other things that possibly are useful for heat and cold therapy. And we may dive into a couple little conditions. However, really with an isolated focus on musculoskeletal injuries. This is actually a blog that Dr. Berlesman created and posted in November 2024. It provided not only our subscribers, but also myself. I learned a lot from this blog, and it gave me some evidence-based guidelines on heat and ice therapy and when we can use both to be the most beneficial for where that patient lives. Where are they in their healing cycle? I would love to take credit for this blog. In fact, I'm going to use some of the infographics and this information in several of my presentations for next year. But the title of the blog is When to Use Ice versus Heat for Musculoskeletal Injuries. If you want to take a look at it, if you're a subscriber, it's on the homepage. Obviously, you know where to find it. If you're not a subscriber, that's okay. ChiroUp.com, on the top nav bar, you see a resources tab. If you dive into the blog section, you can find this blog. And of course, we have our webinars and we have our podcast and everything else on that one section.
It's a really nice introduction. Where's the snarkiness?
It's coming. Don't worry.
Oh, that's good to know. This was a fun blog because it changed the way I practice, and that's what it's all about, evolving, saying what can we do differently to help get our patients better more quickly, and especially tools that we can teach them. This is essential patient education. And certainly heat and cold is one of those fundamental things that plays a valuable role in managing pain, promoting healing. But those mechanisms between heat versus ice differ radically, so selecting the right one makes all the difference. The good news is we're going to dive deep into those today.
Yeah. All right, so first things first, let's put an outline on today's podcast. What is cold therapy, and then we'll dive into what is heat therapy. To start things off, let's go through the mechanism of action for cold therapy, and then we'll go right into the benefits of cold therapy.
Yeah, perfect. We all understand that cold therapy causes vasoconstriction, where vessels are going to narrow down, which means the vessels that supply the nerves are also going to be narrowed down. That means the nociceptors are going to be suppressed, and also muscle excitability is going to be suppressed. So we get pain relief from it. We get a decrease in the muscle spasm by that vasoconstriction, and we certainly get decreased swelling. We're going to minimize the fluid buildup in that injured area through that vasoconstriction of the arterioles and the capillaries to control swelling. The other thing that's happening in that controlling of swelling is there's going to be less leukocytes and granulocytes and macrophages, those key immune cell mediators. So a decrease in the inflammation. And this is where we thought that in the past, maybe this would help to control subsequent tissue damage from the pressure in those inflammatory products. So we would suppress that for prolonged periods of time with ice. And that belief was mainly predicated upon animal models. And we've since learned that maybe not, that using ice beyond 6 to 12 hours may not be the ideal situation. In fact, it may cause more tissue damage in the long run. Even a critical review published last year, or this year, 2024, in the British Medical Journal said that there is no conclusive evidence from human studies that cryotherapy limits secondary injury or promotes tissue regeneration. In fact, it's probably just the opposite.
So, if I understand you correctly, we should really use ice in the first 6 to 12 hours. We're going to use it to relieve pain, reduce swelling, and to slow down the cellular inflammatory response. But if I had to sum this up into one sentence, it would be cold causes shrinkage. Is that right?
Let's use that as a headline. That'll
We
be
can
good.
name the podcast that.
That could be the case.
Keeping those things in mind,
Please don't.
when should I tell a patient to consider cryotherapy? I mean, are there specific utilities, specific conditions that really do respond well to ice?
Yeah, absolutely. That ice is still valuable in that first 6 to 12 hours after an injury, especially something like a sprain or a strain or a contusion, where we may want to control that inflammation. And control being the key word, optimize, not suppress or completely eliminate inflammation. We're trying to optimize inflammation. So 6 to 12 hours is good. The other thing that ice works well for, that's proven by tons of literature, is migraine headaches. Whether we put a cold pack on the neck, which is beneficial to the muscles as well as the carotid artery, or if we put that ice on the head through a cold gel headband or a wrap, that definitely helps our patients with migraines. And there aren't a lot of things that help. Once the migraine is triggered, there aren't a lot of things that help, but ice is one of those things that can help to suppress the symptoms. The other thing is that some types of arthritises benefit from ice. Now, typical osteoarthritis wouldn't, but an acute rheumatologic flare-up, if somebody has a rheumatoid arthritis or psoriatic arthritis, ice therapy helps to limit that body trying to resorb its own cartilage cells, that autoimmune response and all the vascularity. So suppressing that is good, especially in conditions like gout. That's the one that has the most research. Ice that gouty toe. And moving upstream just a little bit to the knee, if somebody has a knee replacement, cold compression therapy after knee replacement does improve recovery outcomes. But outside of that, the evidence is pretty limited for ice helping things.
What about a good bourbon?
Great evidence there. Yes, I missed that number 5.
So let me get this straight. So realistically, coming out of school, being a past athlete, I do emphasize past athlete. I always learned about the RICE principle, and that's one thing that is still relayed to just athletes now. And the RICE principle was the rest, ice, compress, elevate. And this was not just when the injury happened. This was, for the next several days after an acute injury. One of the interesting things you brought up in your blog, though, is that the investigator who found the RICE principle, who published that work, Dr. Merkin, has actually since revised his stance on this, and that ice should actually be used cautiously post-injury. He had a more recent article that said when it comes to ice therapy, we really should be doing exactly what you just brought up in the aftermath of any kind of injury, really 6 to 12 hours. And after that, we're actually going to hinder recovery by delaying tissue repair and actually increase scar tissue formation of that area. So that's one of those things that I always find refreshing. And not that Dr. Merkin wanted to be wrong, but he continued to investigate. He continued to be curious about his past finding, and that now he's able to come up with a new possibility to help these people post-recovery. And that's when we dive into the peace and love approach, which emphasizes that early protection, elevation, avoid anti-inflammatories will limit that inflammatory response. Still use compression, and then of course education on how to how to get that tissue to heal. And then once that acute injury has started to subside, now we're going to follow that up with some controlled loading, some controlled exercise, a little bit of optimism, and then some different movements to start to vascularize that tissue and exercise. So let's take a little bit deeper of a dive into the peace and love, because that's something that we all want to start to educate our patients on. So Dr. B, why don't you take the peace part and I'll take the love part. Somehow that's going to get stitched into a marketing message. I'm worried what they're going to come up with after that.
Yeah, that's a meme. Good work again. I'll take the right after the injury. So that's peace comes in. So we still want to protect things. Remember when Rice went to Price and then went to Prices? Protection is still one of those things that after something has been strained or contused, we really don't want it to be further irritated. So we're going to protect it by limiting movement. That doesn't mean stopping movement. That means limiting movement or making sure that we're getting movement that doesn't damage that tissue. Elevation is still a key, that we would like to get those waste products back out of there. So getting the injured area up above the other areas is still a good thing. But as opposed to rice, which said ice to limit inflammation, now we want to avoid anti-inflammatories. And in the Peace and Love that's detailed in most of the literature, the anti-inflammatories that we're talking about are chemicals, over-the-counter painkillers, anti-inflammatories. Using those, we know, suppresses tendinogenesis. It's going to limit the amount of healing, so don't use those right away unless instructed by your doctor or there's a really good reason. Swelling is a natural reaction. It's part of the body's healing process, and stopping it or dramatically suppressing it actually delays recovery. So that's the big one. Let's avoid anti-inflammatories. One thing that did get to stick around is compression. That putting a wrap around it limits the swelling, it optimizes the swelling, limits the bleeding inside the tissues, and it may help with healing. And finally, education. That patients need to understand why they're doing these things, not just that you're telling them to, but educating them about the injury and focusing on an active recovery, especially preparing that patient for the phase that comes next, a couple of days after injury, where we move into love.
And that's where I guess I come in. I think that this is where things, what we would normally call the rehab phase. We want to calm things down first, then we want to build things back up. So the first part would be loading. Loading isn't necessarily putting someone under load, meaning with weights. It could just be start to move that tissue, or actually just put weight on that tissue again. So something to think about. That doesn't mean we need to, start to use resistance bands and weights associated with the tissue, but we do want to start to load that tissue to build it back up to that same strength or capacity. Optimism is the next piece. Stay positive. There's one thing that continually surprised me is that the optimism, the plan set forth, the confidence you have as a provider makes a huge impact on how that patient recovers. We all know tissue heals. Our job is to continually be there to help support our patients and making sure that we don't use negative words as compared to the positive words that are going to help that patient recover quickly. Vascularization, this is one of those things, like I'm a big walker. I love when I can get my patients out and walking and just to get the blood moving. There is a big difference between hurt and harm when it comes to this, is that if something truly hurts above a 4 out of 10 and is sharp pain or shooting pain, that's harm. You're doing too much too fast. But when something is achy or more just kind of hurts, we can move through those movements. If it's just uncomfortable, we want to make sure we get that person up and out and not just laying around on the couch. And then finally, exercise is the E part of love, that we want to build someone back up to where they were pre-injury. So let pain be your guide. If it hurts too much, we don't want to get them back in too fast. However, we want to make sure we can get them back in their activity and avoid any kind of compensatory movements in our evaluation before we drop them back into their sport. So let's go into the heat discussion. Anything else you want to cover as far as ice before we drive into that?
A couple of things, yeah. If you'd like to learn more about Peace and Love, you can download the infographic. Just visit ChiroUp or check out the blog, and you'll be able to download that in the forums library. And I think the last thing before diving.
Whoa! Wait, one more thing. I have one more question. We just talked about ice, but I guess probably the number one thing that I hear from a patient is how long to apply it. So we didn't cover that. So how long should you apply ice for?
A while. So it depends on the temperature. That ice could be anything, or cooling, and vasoconstriction could occur anything between cool water, as you mentioned, and 0 degrees Celsius. That if you have an instant ice pack, that's going to be very cold. In fact, potentially dangerously cold, that we need some insulation. And insulation is going to be the key to how long we apply that. That if somebody has a lot of tissue between the area that you're icing, it may take a little longer to cool that tissue. If you're putting insulation garments in between there, which we should, depending on the thickness of those, it may take longer, but generally 10 to 20 minutes. And really what's going to happen is the patient is going to go through a series of sensations that we refer to as the acronym CBAN. Cold, burning, aching, and numb, meaning that first you're going to feel cold when you put an ice pack on, then it's going to start to burn, and then it's going to ache, and finally it's going to turn numb. It's time to take the ice pack off when it becomes numb. And this is something, if you haven't experienced those sensations yourself, get up, as long as you're able to put your foot or hand in cold water, put your foot in a bucket of cold water, and you'll see those, of ice water, you'll see those sensations come about exactly as the CBAN acronym. And also the interesting point is when patients say, this is totally off script, but when a patient says they have a high pain threshold, number one, you know that they don't. They have the lowest pain threshold because people who have high pain thresholds don't realize they have high pain thresholds. But the one indicator of your pain threshold is how long you can keep your foot in a bucket of ice water. Some people can run it all the way to numb, and then of course you could keep it there infinitely once it's numb. But many people are pulling it out at cold or burning or especially aching. So if you want to see who has the highest pain threshold in your office, find some cold water, stick your feet in, and first person out has the lowest pain threshold.
I'll tell you what, that's one of the things that I've done with student athletes and essentially my kids, is that I'll get, like Seaver's disease or some Achilles tendinopathy, and dropping that extremity into cold, well, it does a great job of quickly cooling that tissue. So something we can, of course, use. But from what I heard, it takes 10 to 20 minutes to make the magic happen. Is that about right?
Yeah, exactly.
So as far as heat goes, so I guess we can drive into heat because heat's actually the bigger part of this discussion. Let's go through the same flow that we did with cold. So what is the mechanism of action of heat? And then how does this actually work on the cellular level?
Yeah, great question. Just the opposite of ice, that heat is going to cause vasodilation. So we're going to increase the blood flow to the area. And that has several benefits, that there's some pain relief. And we don't think of heat often as a pain relieving process, but it absolutely does, because it's going to stimulate the thermoreceptors, and that's going to then suppress or dampen the effect of and the proprioceptors as well, and it's going to dampen the effect of the pain sensors. So the nociceptive input is going to be suppressed because you've increased the sensation of the thermoceptors and the proprioceptors from that process. We're going to also increase, the big thing is increasing blood flow and metabolism, delivering more oxygen and nutrients to the tissues. That supports muscle function and strength and mobility. It's really helpful in those subacute and chronic musculoskeletal conditions to improve tissue elasticity and muscle flexibility and oxygenation, as well as the connective tissue elasticity is just going to decrease the stiffness in the area. So heat absolutely has a pain relieving effect, as well as an enhancement by providing nutrients that are needed.
So ice slows things down, heat speeds things back up. Knowing those things as far as on the physiological idea of what those things do, can we be somewhat black and white as far as that goes, as far as time? So can I kind of stick to, things 6 to 12 hours, that's ice, and then heat after? I mean, is it that simple, or should we be kind of mirroring these or matching these with diagnoses?
Absolutely. Matching them with diagnoses would be helpful. We know there are certain things that ice is better for. We also have to basically ask ourselves, what do I want to do with this blood flow at this moment in time? Do I want to suppress it a little bit? Do I want to optimize it? And does that optimization mean getting a little more blood to the area? And most of the time, it's getting more blood to the area, especially for the number one thing that we treat, that's lower back pain. That heat therapy has a ton of evidence that's saying when it comes to acute or subacute or chronic nonspecific low back pain, heat is the way to go, including the Annals of Internal Medicine that said, let's use heat therapy. It provides some short-term relief from pain and the disability, and when you combine it with other treatments, those treatments become more effective.
Just to interject again, because I'm pretty good at that.
You are an interjector.
Was that the February study in 2017,
yes.
the Valentine's Day study. One of those, for those of you who remember, the Annals of Internal Medicine 2017 said for acute, subacute, chronic low back pain that we should be, and by we, this is Annals of Internal Medicine, this is across the board physicians, we should be considering using acupuncture, spinal manipulation, heat and massage. And that's the standard of care for those types of lower back pain. However, did anyone else see a surge of patients from their primary care doctors just flooding into chiropractic offices? Because, we get those standards of care, but not everybody follows that. And everybody has their ideas on how to accomplish, treating lower back pain, and they don't want to change your habits. So here's my question. What are you going to do? In light of this information that we should not be using ice past 12 hours, are you still going to be using ice in your clinic for these patients for 3 visits a week for the next 12 weeks? Or can we consider using ice at the very beginning and then going to heat after? So how are you going to change your practice with this new information?
What a great point. That it's hard to do. You get used to doing something, you stay in that, it tends to work for you, but you don't have the evidence to say, it's anecdotal evidence. When it comes to the real scientific evidence, yeah, we probably should be using heat. And we look at MDs saying, why aren't you following the guideline by referring to me now? But there's a few fingers pointing back at us saying, well, why aren't we following the guideline and using heat now? For lower back pain and really any mechanical type problem that's not in the very early acute stages. Once we get into the subacute and chronic, certainly for any mechanical nociceptive condition like a tendinosis or osteoarthritis, once that very acute phase is past for the first few hours, those sprains and strains will absolutely appreciate heat. We also find heat works well for exercise types of things, that it works well before exercise. It enhances physical function and range of motion, flexibility, decreases muscle stiffness, which reduces the rate of strain. That low-level heat therapy a few hours before intense exercise will improve movement and prevent damage during activity. And then post-exercise, it's a little bit of a coin toss. There's a number of studies that say you should ice for delayed onset muscle soreness, DOMS. And other studies said that you should use heat. But really, I think the more conclusive study, a review of 50 studies, said that heat provides the more effective relief in the first 24 hours post-exercise. And then the one other thing is that most experts, there was a consensus panel that came up saying, when should we use heat? And that's where a lot of this information came from, an international group of experts. And 4 out of 5 of them said that heat would be very beneficial for dysmenorrhea as well. So not just the mechanical things we treat, but anytime we want to improve blood flow to an area.
So same kind of question that we had for ice. When should we use, not when, but how long should we use heat therapy? What's the safe temperature range and for how long?
Yeah, this one's a lot more conclusive. It's your hot tub. So 40 degrees Celsius, 104, 105 degrees, it would be the optimal temperatures. It's safe for most of our patients for superficial heat therapy. If you want to increase tissue temperature, that's going to increase vascularization. And depending upon how much you warm that tissue determines how much vascularization. So if you take something to the below 100 degree range, below 38 degrees centigrade, you're going to have a 27% increase in blood flow. If you take it to 40 degrees, which is about 105, you're going to have a 77% improvement in blood flow in the trapezius muscles where this study was done. So that's optimal. And if you really bump it up to 42 degrees Celsius, then it's going to be 144% increase in blood flow. So it's going to depend upon the thickness of the tissue as far as the speed. So if you have a thick tissue with a lot of insulation, it's going to take longer. In fact, 2 centimeters of subcutaneous fat can take up to 30 minutes to get the desired therapeutic effect. So most of the time we say 10 to 20, but if you're on something that's heavily insulated, it's going to take even longer.
So for those of you who want to stick around till the end of the podcast, we will be covering the conversion from Celsius to Fahrenheit. We'll go over the math behind that, just if you want to bring some numbers to all those calculations. Yeah, it's always, I've got a sister who lives in Switzerland, and she's always, telling me the temperature. I'm like, what does that even mean? It's always interesting when you go from our system to the metric system and how much that makes sense. Anyway, that's an opinion, not a fact. Let's go through, if you do have any thoughts on this, and I think there are going to be thoughts on this, because normally I get the thoughts. I get the feedback from all these podcasts, but for this one, I am going to pass it over to Tim. So if you have any questions, opinions, or thoughts on heat versus ice, be sure to email Tim, Tim, at chiroup.com. He's giving me a look right now. But no, realistically, we do like the feedback. I got some feedback from the last podcast, and it was towards the eggs and bacon comment that I make, and I really do appreciate those things. There's so many people that try to pigeonhole us for making a comment versus for the heat versus ice. We're just giving you the evidence, and we're providing some context around it that an evidence-based chiropractor could use. Whenever we get feedback, though, that fuels the next podcast, the next webinar. So we really do appreciate it. Now, let's dive into more of the fun aspect of the podcast. And I have 2 questions. I'm going to ask them to Tim. I have not prepared him at all, which makes it even better. So the two questions, I'll give you the first one first. I don't want to give you time to think about the second one. And then I'll give you my answer, which I have put some thought into. So sorry about that. The first one is this one. What is one thing? Now, this is professional, not personal. It's not that we don't care about your personal life, but we don't. What's the one thing professionally that surprised you this year, 2024?
Professionally, off the cuff, as I'm looking through the door at our office, it would be our team. That as our business continues to grow, we've put a lot of time and effort into developing additional resources. That our team is still so dedicated. That we've got some of the greatest people in the world, and those of you who have interacted with them certainly understand that, from Becky and sales and Kurt, moving through Adrian and the entire onboarding team. They're tremendous. Our product team, I think that's what would surprise me, that we have a group of people who aren't chiropractors, who are still willing to dedicate their lives and beyond what they would ever be expected to give to make our profession better.
Yeah, that was my answer.
I'm glad I went first.
I would echo that. In our first year of having the EHR out in our beta group, I have been, and we had, how many beta clinics did we have? Before we released it, 8. So we had some diverse clinics that were using it to begin with, but the variation in scheduling, in services, in billing, in creative coding, creative business practices are all different. And I knew we were going to get into some clinically diverse situations just by nature of the chiropractic profession. I had no idea how diverse our business ecosystem was, though. I really didn't. 100% honestly. And some people would be like, well, that makes it tough, and you can't scale a product if everybody's doing a different practice. I would disagree with that because I think what we're going to learn is what works from certain clinics, clinically and business-wise, and then we're going to be able to provide a scalable model for those younger chiropractors and to show them clinically and accountingly.
Yeah, absolutely.
That sounds like works. And to show chiropractors how to make whatever model they want to choose, how to make it work for them in the future. So I'm pretty excited for that. Next one, what are you looking forward to next year? So 2025, what happens professionally for I guess for you or for ChiroUp, however you want to answer it?
Well, the new partner search, I think, would be the big one. That's going to be exciting.
Am I leaving?
I would say next year, obviously, the thing that dominates really every second of our day is the EHR, that our profession has such value and such merit, and it's not being shouted from the rooftops. It's not being appreciated the way that it should. I think that we as a profession can truly work together better to harvest data, to move that data to decision makers, to make our profession truly that undeniable best choice. And I don't think that can be done without an EHR that's made by chiropractors for chiropractors with an evidence-based standpoint, and inspired and created by those chiropractors in that network. And so I'm most excited to see what we as a group are going to accomplish next year to advance our profession. I think it's going to be a game changer. We're going to break down some walls, the things that we just talked about. Why don't MDs refer? It's because of their personal experience that we see each other's failures. We're going to be able to change that process. And I couldn't be more excited about being part of that and being part of the network that serves us.
Yeah, learning from the data is probably my number one. So I'm gonna I will have to change my answer for this one because you took my answer legitimately on that one. 2025, probably the events that I have scheduled. I know your events, so I'm sure you're excited, but I can't speak to yours. I've been an anti-mastermind person since I've been in practice. There have been so many masterminds, and I've always seen them as money grabs and kind of exposing people who don't have the information. However, a good friend of mine, Kevin Christie, has one coming up, and I have just been following him for a long time. We both have a similar background in MPI. and I get to go into and to do a presentation for his group. Just very excited to be in like-minded people and just to provide my perspective, not to provide knowledge, not to provide the way to do this or the 7 ways to fix all shoulder pain, is to provide 15 years of perspective and how I can help them. And then, man, I'll tell you what, Parker in March, you and I are both going to be at. That's a changing mindset, is being in school compared to what they are now. If you haven't been to Parker event, regardless of your philosophy, regardless of where you practice, regardless of whatever it is you do, you should see it. It's one of those things that I really like because they give Tim and I, we're not speaking together, fortunately. However,
It's one of their bylaws.
they give us free reign. They just give us a stage. What do you want to talk about? And I really do appreciate that platform.
Yeah, absolutely. I would echo those as well. So we're looking forward to great things in the years that follow. We're proud to be part of your team. We're proud that we can be serving each other. And if you haven't already, if you enjoyed this episode, we would encourage you to share it with a friend. If you learned something new, I bet your friend would enjoy learning something new as well. And let us know what we can talk about in the future to make this even more valuable. It's about pushing our profession forward, and you can help us spread that word by hitting the follow button. Thanks for listening.
Start off 2025 strong, utilizing the best deal ChiroUp has ever offered. $50 off a month for the entire year. For 2025, you're going to get $50 off any plan. That means for as low as $99 a month, you're going to be able to utilize all the new functionality and features within ChiroUp. These features are going to allow you to streamline patient care and revolutionize your practice with new marketing practices and also new things you can do for your patients to get better outcomes. Let's make 2025 a game changer for you and your clinic and join the thousands of chiropractors around the world that already use ChiroUp. Can't wait to have you on board.